Welcome to Ulnar Nerve Made Ultra Easy tutorial. In this tutorial, we will be looking at the clinical lesions of the ulnar nerve. The ulnar nerve could be affected in two types of lesions, the high lesions as well as the low lesions. High lesions could be caused due to a cubital tunnel syndrome where the ulnar nerve is entrapped within the cubital tunnel. It could also be caused by an elbow fracture or even an ulnar subluxation of the elbow joint. The low lesions could be caused due to a pressure of a ganglion, a wrist fracture, or even Guyon canal syndrome. The high lesions, when affected at the elbow area, all the muscles and sensory supply will be affected, from flexor carpi ulnaris, flexor digitorum profundus, intrinsic muscles of the hand, adductor pollicis, hypothenar muscles, all will be affected. The sensation will be lost of the palmar and the dorsal medial 1.5 surfaces because these nerves exit after the elbow. So hence, a lesion at the elbow will cause everything affected by the ulnar nerve to be lost. This is a picture of minimal claw hand which is seen in a high lesion of ulnar nerve. It is usually seen when a person is asked to extend all their fingers. There is a extension of the metacarpal phalangeal joints due to the absence of the medial two lumbricals. There is no flexion of the distal interphalangeal joints due to the absence of the flexor digitorum profundus. The flexor digitorum superficialis supplied by the median nerve is paired, hence there will be flexion at the proximal interphalangeal joints. The sensation will be affected in both the dorsal and the palmar area of the medial 1.5 digits. Now let's move on to the low lesion. The low lesion usually occurs at the wrist. Hence, as you can see in this picture, the dorsal cutaneous branch exits before entering the wrist. The palmar cutaneous branch enters the wrist and all the other muscles supplied in the hand will be affected. The hypothenar muscles will be affected, the intrinsic muscles will be affected, the adductor pollicis will also be affected. This is a picture of a prominent claw hand which is usually seen in low lesion of the ulnar nerve. What is important will be there will be more flexion of the distal interphalangeal joint as the medial two flexor digitorum profundus are working. They are being spared in a low lesion. Let us recap the different signs that you will see in a high lesion and a low lesion. A high lesion will produce a minimal claw hand asking the patient to extend all the fingers. The low lesion will produce a maximal claw hand or a more prominent claw hand because of the working flexor digitorum profundus as it has been spared in the low lesion. All the other intrinsic muscles, like the palmar and dorsal interossei, which helps with the adduction and abduction, will be affected. The hypothenar muscles allowing the flexion, abduction, and the opposition of the little finger will be affected, as well as adduction of the thumb by the adductor pollicis will be affected. The lumbricals still remain affected. Hence, there will be a metacarpal phalangeal joint extension. The sensation will be varying in a high and low lesion. The high lesion will have both the palmar and dorsal surface of the medial 1.5 digits affected, while the low lesion will have only the palmar surface affected because the dorsal cutaneous nerve leaves the forearm before entering the wrist. Hence, the dorsal side is paired. Only the palmar side will be affected. Some symptoms include pain, numbness, tingling sensation, pin needle prick-like sensation, and also loss of sensation over the affected areas. The investigations for a nerve lesion includes X-ray to rule out any fractures or even dislocations, nerve conduction studies and electromyography to check the electrical activity and the speed of the conduction of the nerves, CT scan, MRI and ultrasound helps to rule out all other causes which may cause a lesion. These are pictures of the X-ray as well as the nerve conduction studies. The X-rays are of the wrist joint as well as the elbow joint. It is important to take an X-ray of the bones above and below the joints. The treatment for high lesions at the elbow area include physiotherapy, which will help to strengthen the muscles, pain management by anti-inflammatory medications, heat therapy or massage, neurobion, which are vitamins for the nerves, and if all these fails, anterior transposition of the ulnar nerve can be considered. This is the anterior transposition of the ulnar nerve. The ulnar nerve usually locates behind the medial epicondyle of the humerus. In cases of cubital tunnel syndrome, these ulnar nerves will be relocated in front of the medial epicondyle. Treatment for the low lesion includes the same as the high lesion, except when all treatment methods fail, like physiotherapy, heat packs, pain management, and neurobion fails, surgery is required. The surgery will be the surgical exploration of the ulnar nerve instead of anterior transposition, as the lesion here is located at the wrist and not at the elbow. We have now come to the end of this video. I hope you've gained enough knowledge about the clinical lesions of the ulnar nerve. You can look below this video for several other videos and quizzes to test yourself on this. Goodbye!